We have a comprehensive spine program at Bone and Joint. We have 3 spine surgeons, myself, Dr. Michael McNamara, Dr. Casey Davidson, and then we also have a physiatrist, Dr. Zach Kalb, who's one of our non-operative spine practitioners. He performs our injection therapies such as epidural shots, facet injections. We have physical therapy, all spine specifically trained physical therapists. We have physicians extenders who all rotate through our spine program, are all well versed in spine treatment and evaluation, diagnosis, and treatment. We have diagnostic imaging. We have MRI, which was just now being installed, which probably won't be active for another month or so. Currently, we have a CT scan, and of course, we're very close to Williamson Medical Center, right across the parking lot, which has all sorts of diagnostic studies for all our inpatient needs. And then we have a surgery center for all our outpatient treatment, surgical treatment options. There's a lot of overlap. You would think that it would be very easy to distinguish between neck and shoulder pain. And that's not to say that some people can have both. So you can have problems with both your neck and shoulder, but ideally, I get an idea from the history, from interviewing the patient. If they tell me that their neck started in their neck and then radiates over their shoulder, and there's numbness and tingling and burning involving their muscles and arms all the way down to their fingertips, that sort of tips me to believe that it's more nerve related. If they're telling me that their shoulder started hurting initially and then maybe started radiating up to their neck, it hurts to reach into the back seat of their car, it hurts to reach above their head, and they feel a clunking in their shoulder or mechanical symptoms with their shoulder, kind of leads me to believe that it's more of a shoulder issue, but it can be very hard to distinguish. Yes, so after interviewing and then a physical exam, and the physical exam in and of itself can really help with distinguishing between the neck and the shoulder. Afterwards, if I'm very believing that it's more of a neck issue, we'll get cervical x-rays. If I think that it's more shoulder related, we'll just get shoulder x-rays. If I'm not sure yet, then I'll get both. Yes, so after initial treatment, there are other treatment options that really help with, for me to distinguish between neck and shoulder pain. If I am suspicious that it's a shoulder issue, but I'm not absolutely sure, oftentimes I'll offer or suggest to the patient that we try a shoulder injection, and we can do that during their visit in the office. I'll just numb the shoulder up and then inject a cortisone injection. We'll wait 10 to 15 minutes, and if their shoulder gets better, then I'm pretty sure it's a shoulder issue. If, however, it doesn't get better, oftentimes we'll try some anti-inflammatories, some physical therapy on the neck and shoulder, and then have you return to see me in a couple of weeks. And if we're not getting better, then we'll end up probably getting an MRI of something, either the neck or the shoulder. X-rays are good at looking at bony alignment, but MRIs will show soft tissue abnormalities such as disc herniations, bone spurs, pinched nerves, or a rotator cuff tear. Once we establish where we suspect the pain is coming from through an MRI, then oftentimes we can do an injection. And that's where I get Dr. Zach Kalb involved. He's our injection specialist. We have a fluoroscopy suite here at the Bone and Joint Institute. And if I can see an area where I suspect a nerve is being pinched, I can have Dr. Kalb underneath a fluoroscopic imaging machine guide a needle to that area and inject a long-acting cortisone, combination cortisone and numbing medicine. 75 to 80% of the time, it'll really help with the pain.